naming of curvatures. So we've got our principal. We have our principal areas of the spine, principal regions within the spine: cervical, thoracic, lumbar, into the sacral and the coccygeal. Each of those has a different curve to it. They kind of go back and forth, much like gears. So if you look at your lumbar spine, kind of the easiest place to start, it has a lordotic curve. So So, lordotic. Lordotic curve is this lumbar region right here where it curves outward. And it's going to alternate from one to the next. So we're going to go from lumbar from lordotic to kyphotic to lordotic again. So lordosis is the term in which you have an excessive amount of lordotic curvature. And what does that look like? If I increase this curvature, it's going to accentuate that sacrum outwards. Those people are going to have larger looking posterior ends. It just increases that curve. Now, in doing so, if I crank this gear this way, you guys ever seen those kids' toys where it's gears that are interconnected at children's museums, or magnets on a fridge, and stick one and stick another, turn one, and see how many of the others switch direction it turns them? How do you get a little bit? Great. So if I've got this gear sitting here and I stack another gear on top of it, then if I turn that one this way, it's going to rotate the other one in the opposite direction. So to increase my lordotic curve is going to increase my kyphotic curve just from that torque. It's going to accentuate it and make it more pronounced. So that's why your mama always yelling at you about your posture. Because if you're allowing your shoulders to drop, then that is increasing the kyphosis in your thoracic spine. It's allowing you to increase the curvature through here. And that's going to do two things. The first is it's going to force you in your cervical spine to increase that lordotic curve in your cervical spine as well, because they go opposite each other. So lumbar is lordotic, thoracic is kyphotic, cervical will be lordotic again, and then your sacral spine, sacrum into your coccyx and through here is going to be kyphotic as well. So if I increase that lordosis, the kyphosis in my thoracic spine, then if I'm arcing down, then I have to crank my neck up over time to increase, to be able to see forward, to have a head forward, but that's going to increase the curvature of that cervical spine. Now, to some extent, the curvature is helping provide some stability. But the more we increase that curvature, and we'll talk about this as we deal with the ligaments, the more we increase that curvature, the more unstable the vertebral bodies are on top of each other. Because the more I round it, it means that there's pieces that are considerably farther forward from the Legos that they're balancing on underneath. Which becomes very important as you start looking in this region right through here of L4, L5 sitting on S1, because if I increase that, it's tilting that sacrum posteriorly to where it becomes a slipping issue, and L5 might slip off of S1. Especially if I give it some assistance by hammering it with a lot of gymnastics landings, to where you start looking at issues like spondylolysis, spondylolisthesis, which you've had in ortho, right? So we'll reference that a little bit in a moment. So I accidentally left that out, so I apologize. All right, ligaments. So how do we have the stability built into the system? Some of these are pretty simple. Interspinous, it's going to travel in between the spinous processes. So the names, once again, are trying to help. Intertransverse, they span between the transverse processes. Awesome. Supraspinous, it actually goes over the top of the spinous process, the outside, the most superficial aspect of them. So supraspinous, over them, over the spinous processes. So again, not too terribly difficult. The ones that bug folks are the anterior longitudinal, posterior longitudinal, and ligaments of flavum through their duration. So the reason I grabbed this happy, friendly dude and sits him right here. So if we look at supraspinous, as if you want to strap it, you can. Just good. Awesome. Brilliant. So if we're going to look at this, it's got some very mobile vertebra. Interspinous is going to kind of fill in the gaps between these spinous processes. Brendan, why don't you guys come slide in so we can be more comfy and close and chat a little bit easier. Supraspinous is going to go over the tops. So we stabilize the spinous processes quite nicely. Intertransverse is going to go in between the transverse process, thoracic and the lumbar spine, stabilizing those. So the rest of these guys, though, are form and function kind of to stabilize the vertebral bodies, the anterior, all the way down to the front, which is the deep inside. So there's going to be a ligament that runs over this anterior surface, anterior part of the vertebral bodies. Then there's going to be the posterior longitudinal, which is going to be on the posterior aspect of the vertebral bodies. So vertebral body anterior, vertebral body posterior. Now the mental gymnastics you have to put yourself through right now, though, is that the posterior component of the vertebral body is the anterior part of the vertebral canal. Got it? So if we look at fine. Yay! Okay, so once again. I can give you supraspinous ligament. Easy enough, goes over the spinal process. I can give you the intertransverse ligament. Those are easy. So, vertebral bodies running along the bodies themselves are the Legos that get stacked on top of each other to help support that compressive force. It creates the structure, the spine of the spine of the body. It creates the ability to carry the load. So the anterior portion of the vertebral bodies is the most anterior portion of the vertebra themselves. So that's easy. Anterior longitudinal ligament. Good? Mm-hmm. Now, if I want to see just this guy. So that means we're talking about this. You don't let me draw one second. Okay, so anterior longitudinal ligament is covering up that section of the anterior portion of the vertebral body. Posterior longitudinal ligament is filling in the posterior portion of the vertebral body, which is also the most anterior portion of the vertebral canal. So, anterior part of the vertebral canal, posterior part of longitudinal canal. So anterior longitudinal ligament covers the anterior vertebral body. Posterior longitudinal covers the posterior vertebral body, but that's also the anterior part of the vertebral canal. Okay. Then we have one extra fun little guy. And if you look deep, it's called a ligament of Flat. This is filling in the posterior part, stabilizing the posterior wall of the vertebral canal. So if I'm going to look at this from anterior to posterior on this guy right here squatting on the desk, then on the very front part I have my anterior longitudinal in front of the vertebral bodies. The backs of the vertebral bodies I have my posterior longitudinal. And then the back side of my vertebral canal, that's ligament of Flat. And all of these are geared to help connect segment by segment and stabilize the curvature within the spine. So this anterior longitudinal with a lordotic curve in the lumbar region, this is more on stretch. It's taut in this area for the anterior. It's going to be a little bit more slackened in a kyphotic region. And then it flips to where in my kyphotic region, my posterior longitudinal gets a little bit more taut. And then in the lumbar region, my posterior are going to get more slackened. Okay, so back to ligaments. The three main ones that I just went over: anterior longitudinal, posterior longitudinal, and ligament of Flat. Those are the names of those ligaments as running from C7, or C2, excuse me, C2 down to the sacrum. The ligaments continue on up to the occiput, but we give them some fun, happy, exciting names. C2, second cervical vertebra. Okay, so anterior longitudinal ligament from the sacrum to C2. If you think back to when we were dealing with like the MCL, to where some of those deep fibers blended in with the medial meniscus on the knee, we're getting the same idea here. I mean, again, your body's very interconnected, but the deep fibers of this anterior longitudinal ligament actually run in with the annulus fibrosus. What was the annulus fibrosus?
The other section of the disc.
Very good. So the discs themselves, the outer regions, is that heavier that collagen fiber that handles the shear and rotational forces. And those fibers blend in with the ligaments themselves to damage to one is going to cause irritation within the other. Thickness in the lordotic area. So again, this is put more on stretch in your lordotic areas. Cervical spine, because it's on the anterior, so it's got an increased stretch on it on the anterior surface when it's in a lordotic region, which means that C-spine and lumbar spine. So if we have chronically bad posture, increased kyphosis to where we have an increase in head-up position, we increase that lordotic curve here. Over time, that's going to stretch out this ligament, so no matter how much I gripe at you about correcting your posture, you've already stretched out that ligament to where you've destabilized it to some extent. And the longer you do that, the worse it becomes. No pressure. So from C2 to the occiput, we change names. It's like driving down Broadway Street that changes names 5 times before you get to the other end of town. Same idea, same road, same pathway, but just to mess with you a little bit, we're going to slide out. So, but the name is indicative of what it is. So atlantoaxial. Continuation of anterior longitudinal ligament from C2 to occiput. So the anterior longitudinal becomes the anterior atlantoaxial. Simple enough. Yes?
On our test, do you want us to know specifically like the 2 names for both of them, or do you want us to know also like the 2 layers of collagen and all that stuff?
Wouldn't worry so much. I recognize that it does integrate with the fibers of the discs, but don't worry so much about the deep versus superficial bundles. Okay? Posterior longitudinal, same idea. Sacrum to C2 interfaces with the annulus fibrosus again. So this is on the posterior side of the vertebral bodies. So it's just covering up bone segment of the vertebral body and then covers up the discs, and it runs continuous with those discs. Now, this provides little support in lumbar spine because, again, if you look at that curvature, because it's an anterior convexity, it's going to put the posterior side on the inside of the curve, which means it's going to be slacker. So it doesn't give us a lot of stability in the lumbar spine. This is going to be more important in the thoracic spine. And the sacrum obviously doesn't need the support because it's a fused bone. So. And of course, it gets its own name when we get up to the top. So the posterior longitudinal ligament has a fun name called the tectorial membrane when you get up into C2 to the occiput. So anterior longitudinal, anterior atlantoaxial. Posterior longitudinal has the tectorial membrane. Ligament of Flat. Posterior aspect of vertebral canal. So it's filling in those spaces along the lamina and the spinous processes on the inside of the canal. Changes names. Becomes the posterior atlantoaxial ligament from C2 to the occiput. So that's why I wanted to kind of make a big point of trying to visualize where these things run, because whereas my anterior longitudinal is my anterior atlantoaxial, my posterior longitudinal is not my posterior atlantoaxial. So posterior longitudinal, tectorial membrane. Posterior atlantoaxial becomes ligament of Flat. Try that again?
Yes.
Okay, so anterior atlantoaxial, this one's easy. Anterior atlantoaxial, anterior longitudinal. Okay? So the posterior, the back side of my vertebral bodies is the posterior longitudinal. From C2 down to the sacrum, posterior longitudinal. But from C2 up, way up here. That section's called the tectorial membrane.
Oh, okay. And then.
Ligamentum flavum, which is posterior side of the canal, inside the vertebral canal. But at C2 to occiput, that's going to be termed your posterior atlantoaxial. Okay?
Atlantoaxial?
Atlantoaxial. So atlas and axis, that's C1 and C2.
Isn't that the tectoral?
So posterior longitudinal, which is on the back side of the vertebral bodies. That's going to be
Axial what? That's from C2 to
so in this section, anterior. Dude, come on. There we go. So anterior vertebral bodies, anterior longitudinal, anterior atlantoaxial. Okay. Posterior vertebral bodies, so on the other side of the vertebral bodies. Posterior longitudinal becomes the tectorial membrane from C2 to occiput. That's the front part of the vertebral canal. The back part of the vertebral canal
Okay.
is ligamentum flava from C2 down. And the top part of that one is the posterior atlantoaxial.
Okay.
So if I'm trying to memorize this, AA, the atlantoaxial, the anterior stay together. Anterior, anterior. And we got funky names like tectorial membrane and ligamentum flava. And just remember that your posterior names don't align. Got it? So posterior longitudinal, tectorial membrane. Posterior atlantoaxial, ligamentum flava. Cool? Awesome.
Thank you.
Now, the last one I like is this cool band right here. So we have the supraspinous right here that goes up to about C7. So supraspinous terminates at C7 because we changed the name of this epic large structure. So filling in, so we have this interspinous ligaments and that supraspinous ligament, all of that kind of fills in to become one massive banding called your nuchal, N-U-C-H-A-L, nuchal ligament. This is whiplash right here. So you go slam your head forward and put this into forward flexion and you sprain that ligament, and that's why you're so sore after a front end car wreck or a part. And then your muscles lock up and make your life miserable. So very thick band. I mean, it actually fills in the gap out well outside of the ends of the spinous processes, all the way up into the occiput. Pretty massive structure. So a couple special places. Alar ligaments. So C1 and C2. Good. We're going to hide the others. So we have just these two. So this is C1 sitting on 2, right? So lanoaxial joint. The alar ligaments, they pretty much grab onto the dens to help stabilize that rotation so C1 stays in place. And next we've talked about some. The iliolumbar ligaments, again, help stabilize the lumbar spine into the pelvis itself. So we've already discussed this one from 2 classes ago. But just helps reinforce that this is there to help stabilize lumbar spine as well. To help limit that rotation that it can go through. It helps to resist anterior sliding of L5 onto S1. So it tethers it so that you're looking from that region so that this section through here can't translate too far forward. It's tethered backwards by those iliolumbar ligaments. Further stability. Vertebral body. We have significant loading capacity of these guys stacked on top of each other. But again, about 20% of that load is unloaded, 20% of your body mass is unloaded by these zygopapazile joints, the facet joints that go on either side. So that's your superior articular process, superior articular facet, interacting with the inferior articular facet of the one above it. And so locking this in bilaterally, because we have one on each side, helps restrict anterior posterior shear force. It also helps restrict rotational force. So it's increasing that stability beyond just this stack with some ligaments. It's creating a difference within, it's handling some of those shear forces as well. Now we talk about how everything is connected. So we pull back up muscles, and it won't show it so much. It's going to give me the lats. So, latissimus dorsi on one side. It's a bilateral muscle. It's your lat pull downs, it's pull ups. We'll get to that when we get to upper body. So it acts on the arms to pull them down and in. Underneath that directly we have serratus posterior inferior. Start getting into your abdominal musculature, your external oblique, your internal oblique. So that's a second layer, and then deep to that we're going to get to the spinal extensors. And then deep to that we're going to get to intrinsic muscles that fill in that gutter that's created between the spinous and the transverse processes. So there's a lot going on. Around each of these muscles is fascia. And that fascia is so pronounced within the lumbar spine that we actually name it. It's called the thoracolumbar fascia. Thorax, lumbar, fascia. So it's the fascia that runs continuous from your mid-back through your lumbar, except it's got 3 layers, a deep, a middle, and a superficial. The superficial layer actually crosses over and interacts with the fascia that's on and that integrates with your gluteal muscles, which then connects with the fascia that's integrated with your hamstring muscles. So let's say for a second I have a kyphotic posture. Curve my shoulders through my thoracic spine. That's going to pull that fascia upwards. So thoracolumbar fascia goes through my thorax. If I increase my kyphotic curve and start pulling it from the top, then it's going to put a tension on it from in the areas below in that lumbar region. Or if I tighten my hamstrings, that causes like a posterior tilt within my pelvis, that's going to grab on some of the superficial fibers, which is going to pull it down. So we have a tension with bad posture, poor flexibility on that thoracolumbar fascia from the top and the bottom perhaps, which is going to cause some irritation on the fact that it's wrapped around muscles in the middle. It's going to make it more difficult for those to work. Recognizing that confluence of the fascia from one region to the next is pretty important to at least understand that you may need to deal with that, or at least relieve the pressure in one region on one set of muscles, like releasing your hamstrings to take off the posterior tilt, to take tension off of that fascia earlier on, higher up. So anterior layer, middle layer, and posterior layer. Continuous with quadratum lumborum, and we haven't really talked about quadratus lumborum yet. The middle layer isn't well defined, and the posterior layer crosses over and gets in with glute max and runs continuous with latissimus dorsi. So all that's saying is that your deep fascia, which is the most anterior, is your deepest layer, runs continuous with those muscle layers that are the deepest. The middle kind of blends loosely into everything. And the superficial, the posterior fibers, which are the most superficial, will cross over the pelvis and interact with all of the musculature there. All right. So vertebral function, the things that we're doing, we're managing axial compression, bending, torsion, and shear forces. The compression, your body weight, your jumping, your landing, everything that is gravity-based. Bending are active movements, lateral motions, forward flexion, backward extension. Torsion, your rotation from segment to segment. And shear force to where something pushes the tower from two different directions in opposite movements. Your axial compression is principally managed by the loading capacity of you stacking Legos on one another. You've got that supported with the discs inside. Which part of your discs manage that compressive force? So what are the different parts of the discs that we have? Annulus fibrosus, we've mentioned a couple times today. What's the inside called? Nucleus pulposus, the pulp. Okay, it's the jelly donuts, the inside water balloon. So the fibers of annulus fibrosus are oriented at opposite angles. So we have them overlaying like this, which they're geared to handle shear and torsion a lot more. The inside, that pulp, that jelly donut sac, is the component that adds to helping with that compressive resistance. Now, as we have long-term compression, if things aren't directly in line, like we allow our gears to rotate too far, then we start having creep in which one vertebra might slip a little bit more as the ligaments stretch to where it allows it to sit in a less supported position. You're going to walk out of this section and just constantly think about your posture, at least until next week. So that creep concern is the older the patient you're working with, that becomes more of a reality about how much structure they have left from a little bit of stretch over a long period of time. All right, bending. So example. Bending impacts how we push on those discs. So if I lean one way, it's going to squeeze that disc down, but it's going to open up the gap where it can push out to one side. Much like you would expect if you had a water balloon. You lean on it one side, you may compress that side, but it opens up on the other. This becomes relatively important when we start looking at disc herniations, because that squish, the more that nucleus pulposa is able to kind of push through the annulus fibrosus, it's going to protrude and obscure some of the spacing behind. So an anterior movement is going to push that disc into the vertebral canal. So if you have a herniation in there, that's going to exacerbate symptoms for somebody because it's pushing on your central spinal cord. That lateral bend may start filling in the spaces that we have for the nerve roots to come out in and around those facet joints. So if it's pushing into and compressing on that nerve, then we're going to get sciatica, we're going to get nerve root specific pathology. We'll go back and look at this in terms of dermatomes and myotomes, to where we can actually assess some of those pathways based upon if this nerve root hits this patch of skin, then we would expect to see pathology in just this strip of sensation. That's going to help us tie back into identifying what level of damage we have. Likewise with muscles, if this nerve root hits these muscles, then I would expect to have weakness within a unique pattern that's related back to that nerve being damaged within this muscle. So some of that could be related to this disc and kind of how it moves, and it helps adapt for those spine pieces to kind of move on each other. Torsion. So that annulus fibrosis, it's rings of tissue. And each ring is oriented at 120 degrees in the opposite direction of the one that was on it before. So every other ring is geared to resist clockwise rotation. But the opposite rings are geared to resist torsion within counterclockwise. Awesome. So a risk of rupture when you have torsion with the heavial axial compression seems to overload that system. You torque it, it's how you open up a jar of pickles. You grab it, you twist it, or you take the vitamin bottle, the ibuprofen, right? So you've got to load it and then twist it, and it breaks that, it separates that. You're taking these fibers and doing the same thing. They can handle a twist, but if you push down and crank, boom, you're going to rupture some fibers. You rupture those fibers and we start looking at disc herniations. You weaken the walls that contain the nucleus pulposus, and that stuff starts pushing through and bulging. And the lower we get, the more resistance we have to torsion. Your body gets more reinforced to handle that. So increase from T1 through T6 all the way down through L4, it gets stronger and more resistant, because it has to as we get more dynamic in our movement capabilities as we move down. So shear, tend to cause translation. exact same piece that was over yesterday. Okay. All right. So what we got here is your lumbar spine going into your sacrum. Now with that lordotic, that anterior convexity where this is protruding forward, but then we bring it back for the interaction with the sacrum into the pelvis bilaterally. We're getting a little precarious in terms of how we stack those Legos. So that shear force, gravity is pulling us forward. Yet our principal base of support is in the back. So shear force is coming simply because we're exposed to gravity. Now, this piece here, these, in the lumbar region, the vertebral bodies are wedge-shaped. So they're larger anteriorly than they are posteriorly. So part of that creation of that lordotic curvature is from the size of those discs. Or not the discs, but the vertebral bodies and their orientation to each other. Okay? And if we go and we add in Alright, we add in where we would expect to have our center of gravity, our center of mass, you're going to find that where I have 5, 4, 3, L3, L2 sitting on L3, L2 on L3, L3 on L4. They're very much in a nice happy column. So an anterior gravitational pull isn't doing a whole lot. They're doing okay. But as soon as I get to L4 on L5 and L5 over S1, that center of mass is clearly in front of any bony component of S1. This is trying to slip off of this. L5 is trying to jump ship. There's a shear force separating the stability that the SI joints bilaterally, and all of those superior and inferior portion of the SI, the iliolumbar ligaments coming off the ilium into the distal lumbar, and then the anterior SI ligament with these joints themselves. This is anchored. And this, with gravity, is just wanting to creep forward. So we start having issues. So one of the main things holding it back are these facet joints that are angled kind of at a 45 degree a little bit to catch it both as a lateral force as well as an anterior-posterior shear. So there's my facet, kind of with an oblique orientation to handle shear forces side to side, is sit here. So it's going to keep this from moving forwards and backwards, but it also is enough at this angle at 45 degrees that it's keeping the superior from shifting off the inferior. So with poor control, with that concept of creep, where we allow this lordotic curve to accentuate over time, and we stretch out this anterior longitudinal ligament that kind of allows it to structurally move forward, then it puts us in a position that this becomes grossly or more increasingly unstable. Certain sports put a higher demand on this. The two biggest places you see, gymnastics is one for sure. They land with an increased lordotic curve frequently. They land sticking it like this to where that booty gets stuck out a little bit farther. Accentuating this, destabilizing L5 over S1, or L4 and L5. So the biggest piece we have resisting to help are facet joints, and the weak point we have is pars interarticularis. So you get that fracture on spondy in between the pars because that's the only thing left that's geared to handle the compressive force in preventing a shear translation. Good? sort of. The other place we have it are football linemen. Because as they come up off and they go to hit the next guy, bigger, better, stronger, as we start getting our guys up into 300-pound ranges, that if they don't have core control here, that they're not hitting through their whole body, but they hit while arcing their low back, they start getting some of those same symptoms. So you get big football player and itty-bitty gymnastics. And they both break the same spot. Gymnasts are a little more proficient at doing it though. How's that? Bony landmarks. Recognize those pieces. Vertebral bodies. Good. So, simple enough. Vertebral bodies. Pedicles. Goes into my transverse process. My lamina, which blends bilaterally into your spinous process. And then on a different view, I've got superior and inferior articular facet separated by pars interarticularis. So form and function for each of those. The outside rim is cortical bone, the inside structure support, and the primary support as you flow through the projections is that trabecular bone. And there's more of a horizontal and vertical fibers of that trabecular bone that don't intersect well, specifically when we get to the anterior portion. So my vertical fibers don't intersect well with my horizontals, leaving me a weakness in my anterior compartment, making that particularly susceptible to compression fractures. So if somebody lands falling off a roof, boom, that jarring force is going to take all your body weight and crush down here, and that collapses as a weak point. Series of ligaments that help stabilize, restricting the excessive motion that we do. Supraspinous and infraspinous and interspinous, which leads up into ligamentum nuchae from C7 to the occiput. The intertransverse that go along the sides that help restrict lateral bending. And then those three layers that help stabilize the vertebral bodies and the vertebral canal. Anterior longitudinal, posterior longitudinal, ligamentum flava, and at that C2 to occiput range change names: anterior lanoaxial, tectorial membrane, and posterior longitudinal. Clear? Good? Okay. Let's do a little palpation. Let's find stuff to help reinforce the fact that it sticks in your brain. Okay? So what I would like is partners. One person is going to be lying on a table, and then we'll do some work to find where some of these things are on each other. So we'll do a few minutes of one person down, and then we'll switch so you guys can get your hands on. So why don't you just set that anywhere. Looks good on the floor. We'll just leave it there. Cool. So find a partner, clear a desk. Let's go.
Does it pause it?